Next, Dr. Asirvatham and I discuss atrial fibrillation, drugs versus catheter ablation, what to do in 2012. Welcome to ACCEL, and why don't you give us a summary of more or less what you think is important in making these decisions between medical therapy and ablation?
Thank you. One of the few fields where really there's been a sea change in how we approach patients is atrial fibrillation over the last 10 years. Today, a patient with symptomatic atrial fibrillation has the options of medical therapy or interventional therapy, mainly ablation. I should stress that the key issue is the symptoms with atrial fibrillation. Radiofrequency ablation shouldn't be thought of as a cure for atrial fibrillation, but rather a management strategy, either on top of or instead of medical therapy, for patients who have lifestyle-altering symptoms despite attempts at controlling their ventricular rates with atrial fibrillation. A typical patient will be someone who is 55 years old, recent onset of atrial fibrillation, rapid ventricular rates that give rise to palpitations and fatigue. A primary care physician would often have attempted rate control with an agent like a beta blocker or a calcium channel blocker, and the patient may have had side effects either from the drug or inadequate rate control. Then the decision becomes, should we try to control rhythm with a drug or consider radiofrequency ablation? Drugs that are available at present include class 1C drugs like propafenone or flecainide, or class 3 drugs, potassium channel blockers like amiodarone or sotalol. Amiodarone's side effect profile in the long term precludes its use in younger patients, and the other drugs have efficacy rates somewhere between 30 to 50% at a year. Most patients who have failed one or two drugs and are still symptomatic are our typical patients for ablation. Today, ablation is about a 4 to 5 hour procedure and involves placing catheters in the left atrium and electrically isolating the pulmonary veins. This procedure alone is effective in about 70% of patients with paroxysmal atrial fibrillation. Patients with heart disease, structural heart disease, and who have had atrial fibrillation that's chronic require more aggressive ablation therapies, which are an evolving strategy at present, but include, in addition to isolating the pulmonary veins, manipulation of the cardiac autonomics, as well as linear ablation in the atrium. To summarize, it's a case-by-case decision, and the main factors to take into consideration are, is the patient symptomatic? Has the symptoms persisted despite at least one attempt at rate and rhythm control with medical therapy? And if not, with appropriate counseling, then radiofrequency ablation becomes the next step.
Thank you. That's a very good summary of where we are right now, and I think your emphasis on letting the patient's symptoms help to make the decision is an important one because, again, we can, in many patients, particularly older patients, have them be very comfortable with rate control and with a reasonable amount of medications. And sometimes in younger people, as you mentioned, it's more difficult. They're more symptomatic. I've even encountered 40-ish, 45, 48-year-old patients who want to play sports, and they don't like atrial fibrillation, not only the fibrillation, but the anticoagulation and everything else, and we'll have to discuss that for a minute, too. So if I tell a patient who gets atrial fib maybe once every 2 weeks for a few hours and is on anticoagulation and some medication, that we can improve that if they're very symptomatic or annoyed by that we can do an ablation, and that would probably improve that maybe to no events in a year or 1 or 2 events in a year with a little bit of medication, less medication usually. Never sure that I can convince the patient to continue on their Coumadin because a lot of people think they're done with their Coumadin when the atrial fib is ablated. So a couple of questions. The patients will ask me, what are the risks of the ablation? Knowing that if you can't control symptoms, you want to do it. What can I tell the patient about the complications or risk of an ablation procedure?
So the main risks of an ablation procedure are with catheter access. So bleeding where we access the femoral veins or the jugular vein, The more serious complications involve perforation, cardiac perforation, which occurs about 2 out of 100 patients and usually can be managed by just draining the pericardial fluid. A more serious complication is stroke. Stroke occurs about 1 in 500 to 600 patients. Fortunately, most are minor when they do occur. We try to prevent them with heparin during the procedure, but an absolute way of preventing stroke with ablation is not known. The life-threatening complications with ablation involve a fistula that forms between the atrium and the esophagus. The exact incidence is not known, but it's probably less than 1 in 1,000. And recent advances where we limit energy delivery in the vicinity of the esophagus appear to have made this complication extremely unlikely.
You haven't mentioned pulmonary vein stenosis. I know that was early on a concern, but it seems that with the new technologies, it's become much less of a problem.
Yes, pulmonary vein stenosis is a very serious complication. The key to avoid it, which has been now recognized by most electrophysiologists, is to avoid ablating inside the pulmonary vein. So even though the focus of arrhythmia may be in the vein, the ablation is done in the atrium away from the vein. And as long as that's appreciated and done that way, pulmonary vein stenosis is extremely rare and, fair to say, just about eradicated in large centers.
Okay, so basically we have an opportunity to provide a patient an alternative to medication, and many times I think all of us experience the problem of continuously increasing medications till the side effects are even more unbearable than the atrial fibrillation. And then the other question is anticoagulation. And so many people would like to say, I want to stop taking Coumadin. What do you usually tell the patients? How do you determine whether they're getting recurrent AFib that's asymptomatic, for example?
What I tell patients is that to date, there is no proof that radiofrequency ablation, even if successful, reduces the risk of stroke. So whether or not an anticoagulant like Coumadin should be used is a decision made independent of whether we do an ablation and whether the ablation is successful. The decision is mainly centered on the associated risk factors for stroke. So hypertension, diabetes, structural heart disease, congestive heart failure, and previous history of stroke. If these risk factors are present, especially if 2 or more are present, regardless of whether ablation is done, the patient continues on warfarin. It's important to appreciate that even if monitoring that's done fails to show recurrent atrial fibrillation, as long as the risk factors were there and there was a history of atrial fibrillation, we still continue the warfarin. I explain it to patients as saying it's an epiphenomenon. It's something like gray hair and wrinkled skin. They go together. Even if you color the hair, the wrinkles don't go away.
That's a very good analogy. I think it's important for most of us to tell the patient going into an ablation that this is going to improve their symptoms, but it's not going to change the management with anticoagulation. Well, let me thank you for a good summary of where we are with AFib ablation. I think this is very helpful, and thank you again for being here at ACCEL.
Thank you.